Okay, so as I was saying just a little bit earlier, it's a continuation of the same discussion that we actually had last time, where we finished up by talking about anterior guidance. You know, uh, all of you who have heard my lectures on and off before, you all know that my discussion, my position on anterior guidance is somewhat very fluid, meaning that it is something that's not only one way to do it for everybody. It has to be really customized for everybody. So, um, you know, I think more or less we're going to be repeating the same thing over and over from my position, but the way that Dawson talks about it, he does reiterate and emphasize. As I said many times before, this book, I think the book repeats many things over and over, primarily because it used to be series of lectures, original lectures, and they would just pick one topic, okay? And then, so you could imagine if I was giving a, series of lectures about occlusion, one day it could be titled anterior guidance, another day it could be titled lower anteriors, another day it could be titled, as we're going to be talking about after this, long centric. And they're all related topics and they're all in the spectrum of continuation of the same topic. But it does give us an opportunity for us to emphasize and go in a little bit more in depth. Okay. So let's talk about the starting point for the occlusal scheme, page 178. And the title there, or the first topic is lower anterior teeth. And he says, Dawson says, do not downplay the importance of the lower anterior teeth. The arrangement of the entire occlusal scheme starts with the lower anterior teeth, just as the erupting lower incisors are guided into position by the tongue and lips before the upper anterior teeth erupt. So too must lower incisal edge position be determined before the position and the contour of the upper anterior teeth can be finalized. And that can be a little bit of a confusing statement. So let me just kind of like take it apart a little bit for you. You know, he's referring, those of you who have had babies, um, he's referring to the fact that when babies are born, either they are born with lower anterior teeth partially erupted. Sometimes they do come in like that, or shortly after they are born, their lower front teeth starts to come out, the baby teeth. So most of the times, we actually have lower incisor teeth erupt, come into play before we actually do get any upper teeth, at least in terms of developmental sequence. However, however, um, from a restorative perspective, from a prosthodontic perspective, I think it's confusing, even though it's difficult concept for the beginners. I think it's difficult to um, uh, insert that, assert that lower incisor is the first one. Lower incisor is obviously critical, but lower incisor doesn't mean as much if you don't have the upper incisor, because as you know by now, and as you read all this, he spends great deal amount of time that he relies on phonetics, just as you all know how I've been emphasizing over the years. Phonetics, phonetics. Okay? And you cannot make the sound that you're looking for only with lower incisor teeth. The way that we're going to make the sound, the S sound specifically, you have to have both upper and lower teeth together. Okay? So they have to be positioned at the same time. You have to fiddle with them at the same time. Okay. And then I told all of you, if we were to go with reconstructive method, actually what makes sense more is to determine where we're going to be with the upper front teeth. Okay. Now, as you read the book, this section, I hope you did, you realize that what Dawson said is that when we are speaking, that you primarily only see the lower front teeth. And as you probably are, I hope you're looking at me. Maybe you're not, but if you were to look at me right now, you're gonna see that it's my upper teeth are not visible at all. It's just my lower teeth that are visible, just as Dawson emphasized. Okay, it is true, especially as an individual is getting older. Whether we're gonna attribute that to droopiness of the lip, okay, whether we're gonna attribute that to the wear of the incisal edge, whether we're gonna attribute that to prominent development of the mandible. In my situation, it's more so because I'm skeletal class 3. Okay. So you have to think about all these aspects as you're trying to develop the contour and the position of the lower front teeth. Okay. But when it comes to the aesthetics part and a typical smile, especially in our society that is valuing young person, okay, young person's smile, I want you to take a look at the page 184, okay, 184, and you can see the bottom two pictures of the somewhat of exaggerated smile and just a little bit of visibility of the lower front teeth. In terms of the aesthetics, we have to know where we're gonna put the upper anterior teeth. Okay, but where the upper anterior teeth end up and the lower anterior teeth end up, their inner relationship, that that ultimately is what we're trying to determine. Okay, so going back again to what I have always emphasized about studying the method of phonetics testing. Okay, just because I have always said that we start out with the F sound. Okay, the fricative sounds. Okay, that does not mean that I hope you remember. That does not mean that I said that they are they that they make themselves easy to determine where they should be. Remember what I said. So F sound or V sound in English language, okay, is determined by where the upper incisal edge touches the lower lip wet dry juncture. And I believe we talked about that is not going to be the highest point of the lower lip. It will actually be slightly inward, slightly lower, and slightly in, right? And then I hope you remember that that because obviously it's going against the lower lip, which is a soft tissue. There is no not only soft tissue, but there is, for all practical purpose, the lips themselves don't have any bone support, right? So it's very pliable tissue, okay? And we need to make sure that we recognize there is going to be a lot of variability, okay? It's a wide range of acceptability that depends on one's aesthetic preference as well as one's tolerance for how much work you want to do. Okay. And your so aesthetic preference of the patient, but also the aesthetic preference of the doctor. Unfortunately, a lot of the doctors superimpose their value, their idea of what a person's smile should look like onto each one of their patients. So it's the doctor's bias, lab's bias, patient bias, preference, that will determine where the teeth want to be. But I would say at that point, you need to validate it, and know that it at least falls roughly within the F sound guideline, and then definitively how it relates to the lower teeth. They have to go hand in hand. If you overlook this, you're going to always have problems. That's going to be a sort of like a roulette game. Sometimes you win and sometimes you lose. Okay? So so please remember that. And that this is the important thing here. So if you go down the same page, 178, I'm back in 178 again. Okay? About halfway down the left-hand column, Dawson talks about aesthetics, phonetics, occlusal plane, anterior guidance, and stability. Okay? And then, he talks about aesthetics. During speaking, the most visible part of the dentition is the incisal half of the lower anterior teeth. Okay? Also, correct positioning of the upper anterior teeth depends on the lower incisal edge placement. So he's now saying that upper incisal position depends on the lower incisal position. And I would like to just emphasize it's a two-way street. It's a two-way street. It is true that I think I understand why he says the upper teeth depend on the lower, because in most class 1 patients, when they start to develop malocclusion, and when they start to develop too much anterior contact, assuming they have full set of teeth to start with, it is usually the uppers that suffer more in terms of structural breakdown, chips, wear, break of veneers, fremitus, okay, veneer or crown, breakdown of those. Fremitus, periodontal breakdown. Why is that? Because the lower teeth are, the way that lower teeth are lined up, if you were to push against the upper, lower teeth don't really go too far in a class 1 occlusion because they are in an arc. They collapse onto each other. So if you were to look at page 181, if you were to look at page 181, figure 18-3, 18-4, okay? So 18-3 shows the sound where they're making the S sound, and you still maintain the anterior overbite rather. Okay? So if the lower teeth and the upper teeth are touching each other too much, assuming that upper teeth are getting pushed outward and lower teeth are getting pushed inward because they're hitting too hard. The lower teeth, because of the way that they are lined up, cannot collapse onto itself because that's what it has to do in order for them to develop at least fremitus or periodontal problem. Okay? Upper teeth, it's much easier for them to develop the fremitus because there is nothing that's holding it back. Okay? The arc of the upper teeth can flare out like this, much easier. So, so in that sense, yes, it is the upper teeth that are at the mercy of the lower teeth. So when you have somebody who shows you a smile line in an anterior smile and then say, I don't like my number 8 sticking out. As obvious as it is, you need to see if that's because lower number 25 and 26 are sticking out. You need to determine that before you promise that patient that I can redo that composite by doing a veneer. I cannot overemphasize that. When you overlook that and you promise, veneer will get rid of your composite keep chipping, next thing you know, in 2 to 3 years, your veneer is gonna start popping out. Okay? So it is true in the sense that the fate of the upper teeth, oftentimes, especially after aesthetic work, will depend on lower anterior teeth alignment. And then next chapter when we talk about long centric, maybe even the movement, and certainly during phonetic testing. Okay? So so you have to keep that in mind. When you want to establish ideal work for the patient and when they are looking for aesthetic smile, uh, you know, please remember, please remember that that they're gonna oftentimes push you to do the least amount of work. They would normally say, "Let me just do the upper first, and I'll come back for the lower later." Or let me do the front teeth first. I'll come back for the back teeth later. But that sets you up for failure. Even if they do come back, let's say 6 months later after they make money, and now they say, okay, let's do the work on the lower. Well, during the first 6 months, upper anterior teeth have been taking a beating. So now you have longevity compromise, even though they have not broken apart, but they've been getting a lot of beating. It's kind of like if you if you abuse your car, okay, if you abuse your car, and then afterwards you decide, okay, I'm gonna be nice to my car. I mean, hopefully it won't have a long-term, long-lasting effect when you abused it, okay? But that abuse from before may have done some serious damage, you know, and that's gonna accelerate wear and tear. Okay? So so you have to make sure that you understand that the critical aspect of harmonizing both upper and lower. Okay, the so it's important how he talks about aesthetics as of number one in the scheme of how to determine the lower incisal teeth, uh, um, and in our current reality, I don't blame him talking like that because that is what most people are looking for. Okay, um, but please remember, aesthetics is only as good as if the patient is able to talk well, and at the bottom, if there is a stability of those teeth. Okay, so we'll continue to talk about this, but I just wanted you to emphasize, okay, that he's talking about aesthetics not because aesthetics can survive on its own. He's talking about aesthetics because that is how most people want to approach with. That's how they want to have the um, um, how should I put it? That's their primary focus from a patient's perspective. And I get it. We cannot um, forget about that. Okay, but okay, but it is critical to remember. Okay, it's a close result of our ability to speak and not break down things. So he says second aspect of it is the phonetics. The spatial relationship between the lower incisal edge and the opposing two surfaces are critical for the formation of various sound patterns. Their relationship to the tongue and lips also affects phonetic formation. Okay, remember, especially the lower front teeth. Okay, you know, if you have the lower front teeth that are too, shall we say, let's go to the page 182. Okay, yeah, 182, figure 18-6. Okay, so he's actually demonstrating sound, the sound. Okay, but what I wanted to emphasize there is this. Take a look at where the lower anterior tooth is, okay, and its relation to the upper front teeth in terms of the overjet. So let me describe it like this. According to the how those teeth are lined up, and let's say if my patient has in the phonetic and the range of motion, the patient can move up forward. Let's say that overjet is approximately, let's say, 3 millimeters over there in that drawing. Okay, the way it is right now. If my, okay, 3 millimeters. Now, when that patient is speaking, let's say the patient moves forward 2 millimeters forward with the S sound. Okay. If the lower anterior teeth were very tall, so that it can almost touch the very end of the incisal, I'm sorry, lingual contour from exiting from the root before it has the curvature towards the incisal edge. So, imagine class 2, division 2 situation. Then those front teeth will bang onto each other. Even if you look at the case with a 3 millimeter overjet. Okay, so try not to measure the overjet with the widest perspective. Oftentimes, you have to look at where is the closest point they're going to touch. So if the upper teeth are flared out like this and it's touching like this, the overjet is not here. If you think about it, or long centric is not measuring this, it's actually measuring right here. So let's say if the patient does indeed require 2 millimeters for the range of motion, this patient is stuck here. Now, if you are redoing the lower front teeth, especially with implant restoration, instead of making the teeth come up like this, just because the patient had it like that, what if I made it here and then lowered it a little bit? Now I may have 2 millimeters of anterior posterior movement that I need. But my lower teeth are now shorter and more forward. Now, how do you know that the patient is going to accept that? I know that I'm actually getting ahead of myself, but that's the whole thing that Dawson talks about rest of the chapter, talking about how to do the diagnostic wax up and then to do the adjustments afterwards in provisionals. Okay? So it is important. And I think the reason why I wanted to jump in here is because actually, you know what? I'm going to go back and I'm going to come back here. Just remember, by the time I come back to page 182, that I talk about figure 18-7. Okay, 18-7. Okay, all right. So, so then we talk about occlusal plane. We don't want to have a reversed or inverse curve of Spee. Okay, so I guess I just should talk about it a little bit because now that I use the word curve of Spee, if you were to look at the picture of the occlusal plane on figure 18-7, does that look like it's a optimal curve of Spee? I don't want to use the word ideal because that's a little too much. But does that, you guys are all by now experienced dentists, okay? When you look at that, does that give you an optimal curve of Spee? I'm gonna dare say, not really. That's actually exaggerated because the lower anterior have over erupted a little bit. So then why does Dawson says that's ideal occlusal curve along lower incisal edges? Why would he say that? Because unfortunately, that's what many people have in our society. But that does not make it ideal, especially in America. You know, just because so many people are, you know, overweight, that does not mean that overweight is the ideal weight. Okay, so I really try to emphasize to you when you are diagnosing these cases, when you have such occlusal plane where your lower anteriors are higher plane than the posterior in the mandibular planes, I can assure you that's not an ideal occlusal situation. It may be acceptable, patient may like it even, but that's oftentimes, or actually, let me use the other way to describe it. It is rare that will be an ideal situation. Okay? So, so let's, he talks about anterior guidance, and I hope by now you all know one of the criteria of anterior guidance is to make sure there is no fremitus. Even if there was fremitus before you prep those teeth, you want the anterior teeth to be stable after your restoration. There should be no fremitus. And you might say, well, Dr. Lee, how can you say that? Once somebody has fremitus, i.e. mobility, you can't just like magically get rid of it by doing restorative work. And I'm going to say, well, yes, you can by not by making sure it's not hitting too hard. Okay? Fremitus is really a tooth mobility when patient is clenching or sliding their jaws around, right? That's how we can tell. That's why fremitus is defined slightly differently from mobility, even though they are really indicating same thing. So if somebody hits really hard and then keep on pushing forward, you're going to notice more fremitus. But if I make it so that the lower teeth barely touch the upper, barely, through this entire protrusive process, then you're not going to have as much fremitus because the lower teeth are not pushing the upper anterior teeth out. That's how you determine the degree of anterior guidance. And when you go to lectures and when they keep telling you about anterior guidance, you ask yourself, how many of those people actually tell you how to define the degree of anterior guidance? How strong they should touch. Okay? They should not touch too strong. So if somebody says, force your mandible to become a vertical chewer, that's not going to work. That only works with few people. If the patient wants to be a wide-ranging motion, okay, that's what it needs to be. Remember what we repeated last time from the book, okay? Uh, I'm gonna actually go back, because we tend to forget. Hmm. Oh, where was it? Hmm. Maybe I know we went through it. The emphasis on the muscle. Oh, envelope of functioning must have been here. Maybe it was the neutral zone. Sorry. Just want to really emphasize. Yeah, gee. This is what happens. Oh, here we go. Page 128. Okay. When bone and muscle war, when there is discrepancy, when there's a disagreement, disharmony between bone and muscle, muscle never loses. That's what Harry Sichter, MD, said that. And then Pete Dawson goes, when teeth and muscle war, muscle never loses. So when somebody tells you, force, make the anterior guidance tight, they are expecting the muscles to win the war with the teeth. It's going to take a long time. Okay. The teeth will lose. Okay. And if you think about it, going back with all these chapters, we're essentially approaching the same topic from different angles. I hope you don't find it too boring because of the repetition. I consider it very repetitive, to be honest. But I wonder, to be honest, I wonder how many people really recognize that when they read this book alone. They just get confused by one line here, one line there. And they don't see the common theme that runs across. They only think about anterior guidance. And then they make that anterior guidance fit into their preconceived notion, what they already think of anterior guidance. But Dawson's clearly defining anterior guidance as something that has to be within the harmony between the bone and the teeth and the muscles. And he's now clearly telling us today, particularly, okay, that we validate all this with phonetics. That's what we have talked about last time, and that's what we're talking about today. You can validate it with phonetics, and then Primitus checks and all that. Okay? Remember that. And you're not going to get to be good at it until you practice. Unfortunately, in dental school, they haven't emphasized this, just like what I told you about night guard, splint therapy. Dental schools never really help you learn how to do that properly. Okay? So you have to think about these things. Okay? It's critical. Okay. Now, it says the less and then the long-term stability depends on harmony between the teeth and structures that relate to them in function. If the teeth interfere with anatomic or functional harmony of these structures, the adaptive process will attempt to correct the imbalance. The result will be either loosening of teeth, excessive wear, or tooth migration. Loosening of the teeth, i.e., fremitus. Okay. So I I'm not really deviating far from what Dawson is talking about. In fact, I'm probably not. Okay. It is actually indeed other people who tend to oversimplify this too much. Let's go on. Analysis of the lower anterior teeth. The correctness of the lower anterior teeth, anterior segment can be analyzed from several different perspectives. If teeth are stable, function comfortably, and are aesthetically acceptable to the patient, there would rarely be a need to change them. Exactly. If there are signs of instability, evidenced by excessive wear, hypermobility, or tooth migration, or if functional or aesthetic problems are present, changes in teeth position, tooth position, or contour may be required. Okay. Likewise, if teeth are missing or improperly restored, so that positional landmarks have been lost, the correct relationship can be determined if a sequential approach is used in analysis. Some determinations must be made in a certain order. As an example, it is difficult to analyze incisal edge contours until after incisal edge position is determined. So he's saying position the determine the position, and then we're going to talk about the contour. I go, yeah, okay, fine, I agree with that because that's going to fine tune it, right? Incisal edge position cannot be refined until an acceptable incisal plane determines the height of each incisal edge and incisal plane as a group between all of them. How is that determined? All of these is in a relationship with the upper. Okay. Now, analysis to determine the best aesthetics may seem unrelated to occlusion, but every contour has a purpose that is related to function. Thus, it is almost always true that the better the aesthetics, better the function will be, and vice versa. Well, aesthetics is somewhat of a subjective opinion. I agree with them in that sense, but some patients may just want longer teeth than longer teeth. Okay. It is also important to the patient that occlusal therapy does not destroy the appearance of a natural smile. For that reason, aesthetically correct contour should always be a goal along with the determination of what is functionally correct, since the incisal edges are the most visible part of the lower teeth when speaking. Okay. So, restoration of the lower anterior teeth requires two key determinations. Actually, I think three determinations, but I'll say incisal edge position, incisal edge contour. But I wanted to say one more thing, and the reason is because it's somewhat included in both of them, but it would be whether the lower incisal teeth are straight up and down, proclined, or retroclined. Okay? Because if you wanted ideally for teeth to be straight up and down, okay? However, however, because of implants, usually comes down to implants, okay? Whether it be fixed or removable, you actually don't want your teeth there. It's possible because maybe I want my implant screw to go into the lingual of the lower incisal teeth. Sometimes you can achieve that if my implant has to go right here at the same location as my incisal edge. If I have the ability to control the upper, maybe I want to do this. Okay? That's how you determine. Okay? But if I'm going to change my incisal position or the lining, proclining, retroclining position, okay, then I need to just make sure I need to have corresponding change in the upper. Maybe I want to have straight up and down lower incisor, but let's say if my patient's lower ridge is out here, more buccal, and if I place it on the in here, it's going to be class 3 and sometimes a very severe class 3. Well, what do? You're going to retrocline this more. Okay? Now, maybe you don't have to retrocline as much if you can make the upper teeth come out a little bit. Okay? So it's gonna always gonna be an inner relationship between upper and lower. Most of the times, we don't really want to touch the other side, so you have to play this game, opposing. How do I make this fit and this and that and all that? Okay? But if you do have the ability to control upper and lower at the same time, which is the most ideal way, then you can work with them. You can, put them in position that may not necessarily have been what the patient had before. Remember, what the patient had before they lost their teeth is not a guarantee of ideal or optimal teeth position. After all, most likely they lost those teeth partly because their teeth occlusion was not really that good to begin with. And I hope, no priest or minister will ever, or maybe a mullah will ever accuse me of being disrespectful for God when I joke around. Remember how I always joke around. God's got different things to do. He's not gonna fine tune every one of our teeth. No matter how much the orthodontist wants to make them look good. If we asked our orthodontist about, starting point of lower of the occlusal scheme, and then I tell him, okay, aesthetics is important, but how are we going to establish that? Can we do that phonetically? Orthodontist is going to look at me like I came from the Mars. When was the last time I had an orthodontist who worried about speech? Okay. And their idea of anterior guidance is to make everybody look like class 1. Okay. And they certainly don't care about overjet overbite in the sense that allows neutral zone and range of motion. You know, and I don't mean disrespect, but unfortunately that's how the profession has developed. Only thing you need to know about orthodontics, their goal is based on what they show you. What do they show you? Their diagnostic wax up or diagnostic cast, pre-op. Have you ever seen them mounted as it relates to the joint? The only time they do that is if they are working up a orthodontic surgery with oral surgery. And in fact, most of the times when they're doing that, they would usually involve prosthodontist, and it's the prosthodontist who's mounting that case. Okay. So orthodontists will typically just show you upper and lower, very nice looking, soap, ortho soap soaked, very shiny model. Okay. But it could sit on a tabletop with no articulator. So for all we know, somebody who has very severe class 2 would look perfect on that because it has no consideration for the joint. Okay. So remember, okay, remember that that the occlusal scheme, yes, it starts out in the front. Why? Because this is where patient's gonna notice it, okay? But it is determined not just purely by aesthetics. You have to keep in mind the rest of the functional considerations. So let's take a look at what he then says. Lower anterior quality control, incisal edge position, incisal edge contour. He says you determine first, determination, second, communication, okay? And he talks about primarily communication with the lab tech, which is obviously important, and then verification. But there is one more thing that's really overlooked here, okay? And later on when he's showing you that case where they do the wax up and they do the diagnostic cast and then all that, what's really overlooked here is this. It's unfortunate we don't have a good picture that shows, but I think it sort of shows us. Figure 18-10, that's like a full mouth or anterior, upper anterior provisional case. You cannot be lazy and not work out your incisal relationships in provisional yourself, especially if it's going to be more than one tooth. And then expect the lab to know exactly where they go. Lab does not have the ability to do phonetic testing. Your provisional has to be accommodating the phonetics. And then you need to be able to communicate that. That's what I mean by communicating with the lab, to the lab. But what is it that you're going to communicate to the lab? Some contour that you are happy with and that the patient is happy with. So you test it out. So if you don't have the ability to do a decent provisional at the chair side, and if you don't have the ability to, if it's necessary, to move the incisal edges back and forth, up and down, to get it to the point where you want them, you have no right to expect the lab to get it right for you. If the lab gets it right, it's only a luck. Okay? So so that's very important. So that what I would say is determination, communication, verification, absolutely. But it is not just a dentist. You have to let the patient have involved stake in it. And then you deliver to the patient's expectation in provisional, at least within reason. Then you need to either take picture of it, scan it in this day and age, or make mold and then send it to the lab. Okay? Then they have a chance to to fit that for you, to come close to that. Recently I had to help out a friend, another dentist, redo a case lower anterior. And he's a very good dentist, and he kind of gave me this look like, Tom, you always told me that the front teeth should not touch, and I made sure the front teeth do not touch. Now the challenge here was both upper and lowers are implants. Okay. The patient already had the upper implants for many, many years. Now the patient has new lower implants. And my friend is like saying, look, in centric, they don't touch. And then in protrusive, they touch. And yet the patient says she doesn't like it. Why is that? And it became immediately, as soon as I did phonetic testing, the mandible wants to go forward. So it doesn't matter even if there is no touching, because in range of motion, keeps touching. Okay? Minimum centric stop, no traumatic in the stop in the front. Yes, my friend achieved that. But when it came to phonetics, it was too close. So somebody will say, not enough long centric. That's fine. So it turns out that the patient wanted far more anterior displacement. So when I was done, essentially I positioned the patient's teeth down and then like this. My friend had it like this. I had it down and then like this. But it was actually almost to the down here. We're very severe, very much exaggerated. Okay. And then my friend looked at it, and then guess what? So I first did that with provisional. That's right. I should not forget that. I did that with provisional first. Patient was happy. Okay. So it ended up that patient didn't really have a lot of this movement. Okay. But what I needed to do was to bring it down so they were almost edge to edge. So if the patient is going back and forth, okay, it doesn't have a lot of overbite that interferes. Okay. And it was a big 7 unit anterior bridge, lower anterior bridge. Okay. So then after I have done that and I sent the model, the impression of the lower anterior, temporary. And when you are doing that, okay, when you're taking the impression of the provisional that you're happy with, that the patient is happy with, okay, even if it's just the front, make sure that you have enough back teeth in the model that so that you can mount it properly. Because in this world of diagnostics, what they're going to do is they're going to mount it and then they're going to scan it and they're going to superimpose that onto the new crown and bridge design. So they don't have to guess again. They can follow through what I've done. That does not mean that it comes out perfect, but it definitely comes out better. Okay? So any and all anterior cases, when Dawson's talking about diagnostic wax up and provisionalizing, I could not agree anymore with one emphasis that I need to say, and that is diagnostic wax up don't mean anything until you do chair side adjustment. There is no way a diagnostic wax up will go into the mouth without requiring any refinement at the chair side. Just doesn't work. Okay? So you need to practice that. And if you fall off the discipline, then that's when you're going to become sloppy. And so it is entirely possible that when the lab gives you something like this, and let's say even if it's like a single crown, if I don't have it displaced out adequately, what ends up happening is by the time I grind it so much, if they were too close, by the time I grind it so much, your incisal edge will become so thin. They could literally cut the tongue if the tongue comes and touches it too much. They almost act like a knife edge, literally. And no matter what they are made out of, including zirconia, unless they are made out of metal, okay, they're going to eventually become vulnerable for break off. So some time ago, I think I mentioned to you guys that I had a patient that I did number 9 immediate implant. Not only immediate, but immediate provisionalizing. And the root was lost due to external resorption. Okay. So with the provisional, you could imagine, I made the temporary crown more anterior so I can protect it from the occlusion while the implant was healing. Okay. But when it came to final restoration, I was very blunt with the patient. The reason was because number 23 and 24 was a little bit more buccally oriented. Just like what we were saying. The lower front teeth were slightly buccally oriented, which meant that upper really had to be slightly more facial. If you wanted them perfect, aesthetic smile, then I either had to do a lot more grinding on the lower, or my upper is going to end up with inside very thin incisal edge. And maybe also I may have to do cement retain because I'm not able to get my excess screw hole come through the lingual. And the patient was only in his 30s. So I leveled with him and I said, look, how did you like my provisional temporary? He goes, okay, it's okay. I go, would you mind if I maintain the crown being slightly more buccal? It sticks out a little bit more than the lower teeth or other teeth and next to it. And he goes, why? So I explained to him all the rationale. Before I made the final crown, okay? Patient accepted the fact because I told him, I said, look, you have you have the need for this to be in your mouth for 50 years. There is no clinical study out there that's going to guide me for 50 years. So what I have to do is to make sure I put everything that's going to be favorable into your mouth and pray. Okay? And I said, the most important aspect about your situation, okay? The most important aspect about your situation here is is that I want it to last long, and if there is a need for future work again, that it become easier to do the work. That means I want to control the occlusion, and that means I want to make it screw retained if I can possibly do. So I told him that, and he says, "Okay, I like what you're saying, Dr. Lee. I'm okay with this tooth sticking out a little bit." Okay, so that's what I did. The tooth sticks out a little bit, no, maybe about half a millimeter contour wise. Okay, inside the ledge and everything. But that allowed me to do screw retain in the back. And it's been, I don't know how long it's been, but certainly he has no gum recession, no bone loss around that implant. Okay. Now I know that most of my GP colleagues would not engage in that conversation with the patient. They just somehow hope that the lab will do their magic. Now, if you were to have the same conversation when you're trying to deliver the crown, And the patient's going to think that it's an excuse. Exact same conversation if you had a one appointment before, where the patient knows that you have not made it yet, you're about to make it now. Okay, patient knows that you are thinking ahead, that you're way ahead. Okay, so keep that in mind, please. Okay, so again, in the checklist, I know that I get ahead. The bottom of the page 178, the very last sentence. As I learned how important minute details were to the finished result, it became obvious that we needed more precise, verifiable method of communicating every detail. It also meant that before I could communicate any precise detail, I had to determine exactly what I wanted. Okay? So okay? Remember, before you communicate to the lab what you want, you need to make sure that that you know that you have what you want, that the patient and you are looking at it at the same plane. Okay? So the curvature of the incisal plane, the height of the incisal plane, and horizontal anterior posterior position of the incisal edges. Okay? Notice he says edges. Okay? Uh, okay? Um, the position of the edges. So he's trying to not really get into the conversation of procline tooth or retrocline tooth. At least not now. Okay? All right. So when you get to the page, I don't know if this kind of detailed pre-printed lab slip is warranted, but I think overall this kind of the the communication you wanna have with the lab should talk about all these things that are covered here. And if you wanna be really reconstructive and aesthetically focused practice, some of these forms that they have developed, you may wanna magnify and then either copy and paste, or you can just use that type of detail and transfer it to what you're going to be using on a daily basis. Okay. Now, page 181, it says the very first sentence. The curvature of the incisal plane is as important to phonetics as it is to aesthetics. Okay. This relationship to phonetics has a profound effect on function, and mistakes in the contour of the incisal plane are often responsible for problems of discomfort as a result of phonetic disharmony. If the jaw must be repeatedly moved to a strained position to shape certain sounds, the results can be muscle fatigue. Patients may complain of a tired face and difficulty in being understood when they have been talking a lot. Okay. So, just keep in mind, okay, the phonetics is gonna really help you determine exactly where we want to be. Okay. Okay. So as I'm going down, I don't know if you have any questions. So he's telling you S sound. Okay. Now S sound can be made edge to edge or slightly class one, just like what he's showing here, or even very severe overbite. Okay, okay, and then he uses the the. Those of you who are familiar with me, I normally, besides F and S sound, I will throw in J and Ch sound. J and Ch, church, judge. What that does is it sort of exaggerates the mandibular position as it moves in a different manner than S sound, and that can then give you a little bit more indication one way or the other. So it's I think it is let me just read the second I'm sorry, the last paragraph on the left half of page 181. It is a common but very erroneous belief that all upper and lower incisors must be in contact throughout the entire protrusive range, and that all four incisors should meet edge to edge at the end of the protrusive path. If the upper and lower anterior teeth are in harmony with the functional movement of the mandible, there is no tendency to overload them, whether there be um, two teeth or four teeth in protrusive contact with the opposing teeth. So, he's like saying it's okay not to have a perfect thing, but you still need to, you know, respect all these things that we've been talking about. We need to go a little bit more forward. I know it's a little bit early for break time, but I'm gonna ask to take a break time here. I have, oh, you do. Okay, great, Mylene. Okay, thank you. So, uh, I spent last 2 days at the CDA, and I'm a little fatigued, and I didn't get good sleep last night, so I'm getting fatigued a little early today. So why don't we take a little potty break? Because I'm relying on my coffee. Okay, potty break, and then we will have a little longer second half. Okay, so if you don't mind, we're gonna come back at 10. Let's do 10:30, okay? So let me have adequate everybody to get the adequate break time. Okay, everybody? Thank you. Okay, everybody. So let's try to finish this chapter, and then I will have Dr. Mylene's gonna share a case that she's been putting together for everybody to kind of butt our heads together and learn from. So so that we have plenty of time, Dr. Mylene, we can talk about that. So, however, I want to at least finish this one chapter. So. Let's go back to again, page 181. Okay, I'm sure we have, you understand, it just keeps repeating about the phonetics and all that. Okay, let's get to page 182. Okay, this is the important part here. On the left side, left-hand column, the paragraph down there. If the lower incisal plane does not closely approximate the contour of the upper arch during the S sound, another common problem of speech may also be caused. Lisping, tongue getting in the way, that's what he's talking about. But I want you to always remember if sometimes that's because of the interference of the posterior teeth. Okay? So do not overlook that aspect as well. Okay, I want to emphasize, um, that that one of the things that we I think wanted to emphasize here is this. Going back, it just occurred to me when you are checking the protrusive, and let's say if you're doing single tooth, let's say number uh, 24. Okay, when you're going through protrusive, especially if the tooth is an implant or even a veneer or an root canal treated tooth, endodontically treated tooth. I essentially treat anterior endodontically treated teeth, okay, starting bicuspid actually. Okay, anything that's subject to lateral loading, okay, as if they were implants. What I mean by that is I want to make sure that there is no, shall we say, there is no hyper occlusion onto those teeth. And in fact, it's okay to have one tooth not in contact. Okay? So if I can play a little bit of an illusion, okay, so that my number 24 is not in contact in protrusive, whether it's a veneer, whether it's an endodontically treated tooth, or whether it's implant, okay? And you might say, like, well, Dr. Lee, are you cheating because you're overprotecting the tooth you're working on? And I'm gonna say, well, I don't mind cheating if that means my tooth that I'm working on today is gonna last a lot longer. Assuming that the other teeth in the arch is healthy and reasonably strong, it's okay to give a relief for the tooth that requires some extra protection. You have to remember, anterior teeth, if they are endodontically treated, especially lower anteriors, okay, that they are going to be significantly weakened. If you think about a lower anterior tooth, by the time you do a crown prep, there is nothing left in it. In fact, that's the case even if you did the crown prep on a non-endodontically treated lower anterior tooth. What you have left is just pulpal tissue, primarily. So in the lower anteriors, if I can, I will oftentimes do a veneer if I can get away with it. Okay? Especially if the tooth is endodontically treated. I'll just put in a prefab post and then I will do a minimal prep veneer on the lower anterior. That way, the entire lingual wall of the enamel is there to provide the support and the structure. No post buildup will be able to replace the lingual wall of the lower incisor. Okay? If that means, because normally I would charge more for my veneers, okay? But if that's going to be a little too difficult for the patient, I don't mind doing a charging the patient a crown fee for the lower anterior, but I will still do a veneer. And essentially, when I do my veneer prep, it's actually almost like a 3/4 crown veneer prep, so that it has a little bit of a mechanical lock. Okay, but I save that lingual wall enamel so that that's what's going to give me the structural stability. Keep that in mind. Okay, lower incisors are hard, and if you don't prep enough, what ends up happening, as uh, Dawson is talking about, then your contour becomes too thick. Now, if it's upper front teeth, if the contour, lingual contour is too thick, then you're going to get into occlusion problem. If it's lower front teeth and the lingual contour is too thick because you didn't reduce enough, what happens then? It compromises your neutral zone, your tongue space. Okay, which then sometimes cause the patient to do tongue thrusting. Then your lower front tooth that you just crowned may be subjected to going forward more. Why? Because that's the one that's sticking out to the lingual. So if the tongue's coming forward, it may not be exerting as much force on others. But that one crown that's lingually too fat, now it's going to get pushed forward. Okay? So before you commit to a restoration, you have to think about your final result that you're looking for. And in your head, you want to do a prep. What's going to be left? What's my requirement for my occlusion? For me to do my prep. Let me ask you this, because I was guilty of it in my many days, younger self. Oftentimes, I don't check my occlusion on my crown preps until I am committed to doing the prep, meaning I started grinding on the tooth. I know that, let's say if I'm prepping on number 19, let's say if I'm prepping on number 8, okay? I mean, I've seen the tooth, I see the tooth and all that, but I don't specifically, in the past at least, I didn't specifically look at occlusal relationships of those teeth, especially when I'm doing a single tooth, until I'm trying to refine the prep and then I'm looking for occlusal clearance. No, what I would strongly recommend is before you start the prep, take a look at the occlusion first before you prep. Especially if it's in the front, do the phonetic testing first before you prep. That will give you an idea of what it looks like pre-op. And then now post-op or while you're prepping, oftentimes you'll actually see, like, I swear I reduced 3 millimeters incisally or occlusally. Why is there only 1 millimeter clearance? Okay. And that's how we accumulate our knowledge on our cases as we're going forward. Okay. Now, so this is one more thing. Dawson endorsing Tom Lee here on the right-hand column on page 182, second paragraph, the last sentence. Okay, right on top, right below height of the incisal plane. By using phonetics as a guide for functional relationships, we will rarely find that it is inconsistent with either masticatory function or aesthetics. Okay? That's probably the one sentence that is most endorsing of Dawson, okay, for the need for us, all of us, to master the importance of phonetic testing. You want to be good at this, you learn how to do phonetic testing. And this is why I keep emphasizing this over and over. It's just unfortunate. Why is it difficult? You know, I think one of the, if I give benefit of doubt for all the other speakers in occlusion, it is difficult to talk about phonetics when you have a room full of 100, 500,000 people, and to communicate that to the audience easily. It's difficult. You don't get to spend all this time we're talking about right now. And most people are going to say, I know how to do that. That's just for dentures. Okay. Now, now here's the interesting thing. So let you go on to the height of the incisal plane. Second paragraph. Okay. So he's showing you, he's referring to the, actually, I'm going to start reading the first paragraph. He's referring to figure 18-7. Remember that. Okay. Okay. Relating lower incisal edges to the occlusal plane. In ideal instance, the lower incisal edges form a continuous, gentle curve that is an extension of the posterior occlusal plane. There should be no sudden variation in height between the incisal edges and the posterior cusp tip, as where occurs there is a tendency for the occlusal plane, occlusal, I'm sorry, I lost it. Yeah, for the plane to become flatter, but there should still be no sudden changes in height. If the occlusal plane is greatly higher than the posterior, I'm sorry, if the incisal plane is greatly higher than the posterior occlusal plane, that is an indication of elongation of the anterior segment, almost always the result of no stable holding context on the anterior teeth. I disagree with the reason for, but the final result, yes. When the lower incisors erupt, they do not erupt out of the alveolar bone. Rather, the alveolar process itself elongates. Remember hearing that from me? Okay. The entire alveolar ridge comes up together. Okay. That um, rather the alveolar process itself elongates, moving the teeth vertically until stable stop is met. That stop preferably is the opposing tooth, but it may also be the tongue or the lip. The absence of any stop allows the lower anteriors to erupt all the way to the palatal tissue, creating an incisal plane that is at a different level from the posterior plane of occlusion. Well, guess what? Sometimes they don't even stop when they touch the upper palatal tissue. I'm sure you've seen some cases where they start digging into the gum tissue. And they literally cause mechanical recession of the palatal aspect of the upper incisors. In my humble opinion, it's not because they're not touching enough. They are touching, but they're touching at a wrong incline. And they're touching too much. Again, just like anterior guidance, we need to define what we mean by touching in order for these things to be, um, uh, shall we say, stable. Okay? We have seen cases where some patients have anterior open bite, and then they are not even tongue thrusters, so there is no tongue in between, but they no longer erupt. So this idea that they will always erupt until they touch is a false belief. They need to touch in a manner that's functionally ideal, functionally optimal. That means they don't touch too much. That means ideally they don't touch in centric stop. but they touch just lightly, that does not cause phreatus. That's in harmony with the condylar movement. That's in harmony with the phonetics. Okay. It is harmony that is the key word here. Okay. If they touch too much like this, they'll break. And we've seen that. How many times have you seen incisal edge patients, edge to edge patients, where they just wear away? And as they're wearing away the teeth, you can tell the teeth are getting shorter, but they're still touching. And you look at the occlusal plane, incisal plane, it's definitely higher than the posteriors. Okay. So, so some of the aspects of what Dawson is saying is true. Yes, the entire segment comes up, but it is not because they're not touching. Okay, it is because they're touching wrong. Now, the next sentence paragraph. The critical element in determining the height of the lower incisal edges will in most instances be the relationship with the upper anterior teeth. It is often necessary to reshape or position the upper anterior teeth to get an acceptable position and contour of the lower incisors. Yeah, you have to go back and forth, back and forth. This working out of the both upper and lower anterior teeth relationship is the first step in solving most of the complex problems of occlusal male relationships. The goal is to establish stable holding context for the lower incisors at an aesthetically acceptable height. Now, even though that is not his intention, what I will say is this. I agree with in the sense that vast majority of occlusal problems, if not if not caused by, but they are associated with strong anterior contact. And until you control the overly strong anterior contact, whether it's naturally occurring, whether it's byproduct of orthodontic work, whether it's byproduct of other people's prosthetic restorative work, when the front teeth are touching too much, that is oftentimes the beginning of that person's occlusal problems. And in those situations, you need to control that if you want to have long-term occlusal stability. Sometimes you do that by providing splint night guard therapy and then followed up with occlusal adjustment or straight to occlusal adjustment. But you know that I will tell you to caution if you jump straight to occlusal adjustment. Okay? Now, here's the next thing to keep in mind. As we already know, next page, first sentence. Every patient does not look like the ideal norm in the textbook. So trying to adapt every patient's dentition to the average can result in some very unacceptable results. There is merit, however, in knowing that the norms are because they serve as a basic guidelines toward which treatment can be directed. Okay, we can relate the height of the incisal edges to the lips support using the three norms. If we analyze a large number of attractive dentition, we find a consistency in the amount of lower anterior teeth surface that is exposed during certain lip relationships, as listed in the following section. Okay, let's go through real quick. Okay, lips sealed. Next page, lip sealed. So there are some patients, as you are speaking to them, to the patient interview, as you're listening to their dental history, their chief complaints, what you're going to notice is that there are some people who are pouting their lips. In between, they pout their lips. They exaggerate the tone of the lips in order to maintain the teeth closed, the lips closed. That usually means that usually means either teeth are flared out front too much or their vertical dimension is open too much. Because if their vertical is open too much, they will naturally have an open bite, oftentimes, meaning that the posterior teeth have over erupted. Okay? So you need to notice in between their talking, while they wet their lips and when they're talking, okay, they will kind of force their lips to close. And you know that's not in harmony. Keep that in mind. Okay. Number two, speaking. Yes. Okay. Not only is speaking phonetic testing, but also is their movement fluid? Does it look natural? Does it look not uh, exaggerated or extensively forced? Okay. Some people, when they're talking, you can tell their lip and their musculature is really overworked. And oftentimes that's a result of the brain picking up the phonetic interference and they're working very hard to avoid it. Okay. Number three, smiling. Okay. How does the teeth look when they're smiling? That does the what you see in the lower front and the upper front, do they kind of go together? Okay. So for example, if I actually looked at the picture that's next to figure two, speaking, the the first picture, you notice how the lower incisors are taller than posteriors. It's taller than the canines. If you look at that picture. Not only that, number 24 is definitively more anterior than all the others. It is most likely sitting in front of the arc, lower arc. If I don't have a way to control that, in the long run, if I'm doing veneers on number 9, my number 9 veneer is going to be at risk. Okay? Before number 23, 25, 26 cause problem, most likely 24 will be the one that causes most problem. Okay? Is this something you can do veneers on all of them? Well, if you do veneers on all of them, what's going to likely happen? You're going to likely end up with lower 4 veneers that's at the smile curvature of number 24. It is going to be extremely difficult to push number 24 contour to fit to the other teeth incisor contours. Why? Because if you prep number 24 so that you can finish it all the way lingual back, you're going to end up with endodontically involved number 24. But if you made the veneers on number 23, 25, 26 to fit to the curvature of 24, even if you are doing veneers on all of them, now you have all 4 of them that are going to be having potential phonetic interference. Okay? Now, when you look at that case, is this something that we can do as orthodontics, Invisalign? I think there is a small chance you can because those lower front teeth are relatively triangular. So if you were to reduce interproximal contours, make them look more rectangle rather than triangular, then maybe you can fit them all within the arc where number 23 and 26 is forming that arc. That's the arc that you want to go to, which means number 24 is a lot of movement. Okay. But when you send the patient, when you are working with an orthodontist, you need to define that for the orthodontist. You need to go on record telling your orthodontist, this is what I'm expecting. Don't tell them, just make it straight. Because when they make it straight, it's a lot easier if they even if they're doing interproximal stripping, it's a lot easier if they bring rest of them forward. Why? Because when they bring rest of them forward, okay, it gives you more space. You don't have to reduce as much interproximally. Okay? As a restorative doctor, you need to control that yourself. Okay? And if an orthodontist ignores that, you go find another orthodontist next time. Now, sometimes in a situation like this, if you look at it, there is an overlap between number, like, 24 is sticking out. So this is the kind of case that I would actually talk to my orthodontist and my patient about potentially extracting number 24. If you extract number 24 and then you line up rest of them and intrude them a little bit, you don't have to do too much interproximal approximation, and you can actually form a nice inside the arc, new arc. You know, but usually younger people will not go for that, and I don't blame them. But some older patients, they will go for that. Now, what if they don't have the money for orthodontic work, and you have to do some work in the upper front, and you can tell that the lower is going to cause a problem? It's okay for you to make number 9 slightly more anterior compared to number 7, 8, and 10 to accommodate this. But one thing you have to keep in mind is this, that if you leave it like that, number 24 will continue to migrate forward as the patient's getting older. So as long as the patient understands that, and that may end up compromising number 9, okay, then you can leave it alone. But if they go like, oh, if I know that's gonna happen, then we gotta do something. Okay, but if, let's say, if they don't have money for it, I have some more elderly patients who are on who are not cosmetically driven so much, you know, but they are, they have upper teeth that are chipping down and blah blah blah. Um, that I have recommended, just take out number 24, and you don't have to do braces right away. If you don't mind, let it just sit there for about half a year, maybe even 9 months, 12 months. And what you're going to notice in a situation like that is, if you were to imagine the distance between mesial of number 23 and mesial of 25, that space, I'm willing to bet after 6 to 9 months, that distance will become about half of what you see. Because the lower front teeth, now that they are not so crowded, they have an opportunity to move and become a little bit more straight from the pressure of the tongue and pressure of the lip. Okay? So, to be honest, I think right now I can't think of any case that I did opt for that with the patient, and where they closed up everything and I didn't need to do anything more. No, I don't remember anything like that. But I do remember almost always the starting space is almost always reduced. And if they're elderly patients, they will usually tell me, yeah, it's okay, just leave it alone. Because usually the space is actually not right in the midline. Space will be oftentimes between the central and the lateral or something like that. Or if you were to take out a lateral incisor, because that's what was sticking out most, then the distance between mesial of canine and the central incisor filling that space may sometimes work out better. Sometimes I will just fill it up with a little bit of composite on one side or both sides. So there is no more space. Okay. And some people might say, well, Dr. Lee, then you're not doing as much procedure. You're not making as much money. I mean, I understand that, but you know what? If I keep this patient happy, maybe I'll get more referrals. And from there, I'm going to be able to do more cases. Okay. Now, let's take a look at this case here. So on page 185, okay? So you have that picture page 18-8 figure, 18-19, 9, 18-10. Okay. So let's assume that they are moving along. It's the same case. They are moving along. Okay. And they've done the diagnostic wax up. Please remember, just because they've done diagnostic wax up does not mean that's exactly what's going to end up looking in the mouth. It does not. You have to use that diagnostic wax up to initially start, but in the mouth you have to do the adjustments necessary to fulfill all the requirements that we've been talking about. Okay? So diagnostic is just a um, a starting point. And um, and in page 185, okay, on the right hand column, second paragraph, um, the diagnostic wax up is the best possible way to determine lower incisal edge position. Okay, figure 18-8. On many occasions, it is necessary to alter the upper anterior teeth to accommodate an acceptable lower incisal edge position, such as maybe, you know, carving out the upper front teeth a little bit. Sometimes diagnostic wax up is not necessarily always adding wax, but carving on the model. Okay? But come down to the next paragraph and the last sentence of that page. It says, this degree of accuracy can only be achieved in the mouth, and it requires a sequential process for determining what is correct. Okay? What he's saying is, in the mouth, you need to do the adjustments. It doesn't matter how beautiful of a lab support you're going to have, because labs cannot do. They get lucky sometimes. And when they're really good, they get lucky often. Okay? But you have to confirm exactly where you want to be and then communicate that back to the lab. Okay? And once you have done that, if you look at the next page, 186, the procedure page, okay? So what they are doing is, so here on the left, after the lower provisional restorations are approved, after the provisional restorations are approved, an impression is made and a putty silicone index is adapted to the cast and trimmed to conform with the contour of the labial surfaces. Okay? So he doesn't, he skipped one thing. Impression is made and a cast is made. And then the putty is now formed onto the cast of the temporary. Okay? Then when they do the final restoration, the sentence, the index is used, the putty index is used by the technician to precisely locate the incisal edges, the labial contours to the functional restorations, to the finished restorations, copy the cast of the temporary restoration. So that is the idea. The final restoration must copy that of the temporary restoration. That's exactly what I've been saying all this time. Okay? Now, in the digital world, you may not need to do the putty. What you do is a good lab technician who is able to overlay what the provisionals look like as they do the new crown designs. But you need to insist that. You need to insist that. Otherwise, it's a crapshoot. Okay? And look at this. The last picture. He is checking off copy cast of temps. Okay? Now, the next bottom, 186, okay? He says the most important contour on the lower incisal edges is the labio-incisal line angle. And he calls it the leading edge. So take a look at the picture of page 187. If you look at the picture there, the black line, okay, is where the incisal edge and the facial labial contour are making the angulation. The very tip of the incisal edge is marked by the red line at the bottom, 18-13. Okay? You do not want your lower incisor edge to be flat on the top. You want your lower incisal edge to be slightly like this. Okay? That's what he's trying to tell you. That gives you more room for you to dance with the upper incisor lingual contour. So when you are doing occlusal adjustment in the lower incisor, you oftentimes take a tooth that looks right angle, especially when it came from the lab, and you're going to make that right angle blunted, angled, curved. Okay? You don't necessarily often have to make the lower incisal edge get shorter. If you just contour that in, oftentimes you can achieve what it is that you are looking for. Okay? Now, um, if you look at the next page, 188, okay? So, I don't know exactly if that is, I have to assume it was what the author intended, that the lower incisal edges, you see how they are slightly uneven. They did that on purpose. You can see they are slightly proclined. Okay. My honest opinion is most likely they are hitting the uppers a little too much. Okay. But okay. Um, uh, hold on a sec. Okay. Um, so, you just need to make sure that is what you end up, that's exactly what you want to do. Okay. Now, the incisal, the veneer prep, in my opinion, that's acceptable because technically, even though he didn't break the contact, they don't have strong interproximal contact, you can tell. So I can control that contour a little bit better. And they did a slight wrap over, incisal wrap over. Okay. And so you have a definitive seating of each veneer on that. Okay. Now, if when in doubt, especially if I'm doing a single veneer, I probably will be a little bit more aggressive and slightly break the context. So I can have a wraparound effect. And my veneers will not go facially in this way. My veneers will go seating almost like a crown seating. That's how you prevent your temporary and final veneer to pop out to the front so that your path of insertion is occlusal. Okay? Not facial lingual. Okay? Sounds good? All right. Now it's I don't think this is really a coincidence where Dawson shares the example of veneers. The second paragraph at the bottom, 188, it starts at the bottom of the left-hand column. The principles that relate to the incisal edges position and contour apply regardless of type of restorations. The use of laminates for restoring deformed incisal edge contour is an excellent way to restore the leading edge of lower anterior teeth when the labio-incisal line angle has been worn down to steep angular contour. The importance of correct position and contour of lower incisal edges cannot be overemphasized. The entire occlusion can be compromised by instability if lower incisal edges are not correct, if they're touching too much. Okay? Now, Dawson is thinking if they're not touching enough also, because in his mind, if they don't touch enough, they're going to erupt further up. And theoretically, that's possible, but that's not an automatic assumption. Okay? All right. So not so before we get to the long centric, because it's somewhat of a continuous discussion, Dr. Mylene, I'm gonna let you share your slides. I'm gonna make you co-host. All right, I can see it. All right, yes, go for it. Go ahead and introduce us to the case. Do you
Can't
have,
hear that really. No,
yeah, we
sorry.
cannot hear you, Dr. Mylene. Do you have a microphone? You're not muted, so so I don't know if your microphone is not turned on or your earbud is not connected. Can you find what is going on? Is your is your earbud okay? Now you're muted. It tells me. So unmute. Okay. Now when you put your pointer on the slide, I think some of the icons came up in the bottom. Okay, that's a camera. Okay. No. So my guess is maybe your earbud is not connected to your computer Wi-Fi. I can't hear you. We cannot hear you. I know you know how to do it because you've done it before. No? Okay, I think one thing we can try. Oh, no, you closed it. We can't hear you. No, sorry. Well, one thing we can try is, I know you spend a lot of time, so one thing we can try is maybe I can call you and then see if we can use the call as the voice, okay? And I can put your call in a speakerphone, okay?
Doctor,
Yeah.
how about Dr. Mylan shares her screen and then we could help her or guide her with like giving access through the settings. Like Dr. Mylene, we could know if you're using a Mac or Windows, and
Yeah,
then we.
yeah, okay. Let's see. Spoken like a young person, better than me.
No, no.
So Mylene, can you share the screen again? Not the slide.
Presentation, like the whole screen.
Yeah, so when you go to the share screen and then don't click on the presentation, but click on the screen, the whole screen. Can you do that? I know when you don't do this daily basis, you never become good at this. I know. Okay, there you go. Okay, that's your PowerPoint. Now, when they gave you the choice for the screen to share, usually before you click on this, there is another screen example on the top, and that shows everything on your screen, not
Can
just
you
the PowerPoint.
try exiting, like press exit on the keyboard
Yeah,
right now? Maybe.
exit or escape.
Yeah.
Okay, and then go do the share again. Click on the share again, and then it says entire screen. I just clicked on it. It says entire screen. Click on the entire screen. Click on share. Click on entire screen. Oh, you want to log back in? Okay. So Dr. Mylene um, wants to share this ongoing case that she had followed up for a few years, and she's gonna. It's still somewhat of an ongoing case, but she thought that it was a kind of really mysterious case for her. I actually have not seen the case, so I thought it would be a very good opportunity for us to share together and we can think it through. Okay, I see you back.
Can you hear me now?
Yay!
Okay. It's just computer stuff. Let me see if I can share my screen again.
There you go.
All right. Now I'm going on to entire screen.
Oh, okay. Okay.
Good. Okay.
There
So
you
can
are.
you hear me now? Okay.
Yes, 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 yes.
Oh, good. Thank you for your patience. I appreciate it. No, so just FYI, this is my son, and I've limited this slide deck specifically just for this very limited conversation. So it's not everything, but I'll show you what I have. Um, so so this is Lorenzo. He's 18 years old. He was born in Rochester, New York. He grew up in the East San Francisco Bay. He's graduating this month, and he'll start in the fall at Cal Poly in San Luis Obispo. Let me is my let me see if I can lower this here so you can see. Is my little Zoom screen in the way?
No, you're good.
Can you see that okay?
Yeah, we can
I
see
want
it.
you to see his profile.
Yeah, it's okay.
Um, then how do I get rid of this top
Hmm?
toolbar? Is
Oh,
that in the way? Do
that's
you?
just you. That just gives you your
Oh, good.
for you to for you to see so you can control. But we don't see the
Okay.
top bar that you are seeing.
You don't see it?
No.
Okay. So Lorenzo Cangini, he's presently being treated for mild acne, and he's taken tretinoin A. He tends to run low on iron. He takes a multivitamin. He has seasonal allergies and skin reactions to Pen-K as a child. So he has sensitive skin. No other conditions or chronic medical conditions. No history of trauma, like accidents or anything, serious accidents, just minor sports stuff here and there. Which playing basketball, who knows how minor that is in the head, but nothing serious. He doesn't report to have any pain, significant pain anywhere, and no surgical history. Otherwise, his medical history is stable. These pictures were taken in April, and he presents. Um, the reason he's coming to me for this example is because of his jaw pain. He has chronic, mild to moderate generalized jaw pain. And his question is why do his jaws hurt? So that's what his presenting issue is why does his jaws bother him? Okay. So dental history under regular care of a dentist, which was me since he was little. Um, he was always on a regular hygiene schedule, no caries, no restorative history. He started orthodontics at age 13 and a half, and they were removed at 17 and a half. So he basically recently had his ortho off. Um, the patient started to have reporting jaw pain around age 16, off and on familiar pain. Splint therapy was initiated once his braces were off at 17 and a half, and that fractured. A new splint was made, thicker, and much more patient education around his problems, his dysfunction and history, and a lot more patient education for him to be able to tolerate the splint. And many more adjustments were provided in the second splint I made. The patient has tolerated the current splint well and will return for a TMJ eval in a couple months. And then I'll go into detail more about this. So here was his original orthodontic workup. Dr. Jen Martin, she was a referring orthodontist that I used for many years. We worked together for about 10 years with all kinds of cases. So she started treating my son. He's 13 and a half, and this was his workup. So I like to see the beginning, you know, the beginning. I thought it would be useful. He has a beautiful smile anyway.
Yeah.
This is his original. This is before even ortho. But I thought the history, talk about lower anterior, the lower anterior position.
Hmm.
I mean, and look at this on the right and then the left. This is all so interesting to see from the beginning, like when they were a child, how this happened. I'll go on. So this is basically his Ceph and Pano from the beginning. And then this is him now. So we took these pictures in April. No, these pictures were taken in February.
Okay.
He was 18 and a half.
17 and a half.
Well, no, this is the thing is she did a follow-up.
Oh, okay, I see.
She took these records.
Okay.
This is a year after he had his
Okay.
teeth a year after he had his braces off.
Okay.
This is the final follow-up after all the retainer checks and me being lazy getting him in. But this is his final workup, and it was done in February. Not that different from when he was little, huh? like
No,
the
actually there
smile.
is. I think there is less overjet.
Right, right. But the smile, look at this smile here. It's interesting. Like,
Well, the smile is more evened out by dropping number 10, 11, 9, 10, 11. So there was a slight amount of rise up from 9, you know, I would say 6, 7, 8 was pretty good, but 9, 10, 11 was elevated compared to, it wasn't exactly mirror image of the other side. And now they brought it down,
right?
right?
And
Not,
this is his stuff again, his piano.
okay, let's go back to the pre-op stuff. Okay. So now I'm not an orthodontist. I don't know how to do traditional cephalometric analyzing. Okay. But the thing that jumps out at me right now is that when I'm looking at the upper front, I'm just going to primarily focus on upper front. They seem to have been slightly retroclined. If you look at the upper front angulation, okay, and then now show me the post-op again.
This F?
Yeah, Ceph post-op.
Now you said they were retroclined where?
The
What were retroclined?
upper anterior.
The upper anterior is retroclined.
Okay, so this is pre-op. That was pre-op, and post-op. The angulation of which the upper anterior teeth kind of sticking out like this is kind of brought back in a little bit.
Okay.
You can
Let
sort of
me look
see
at the
that
beginning again.
you can sort of see that even with clinical photos. So they look more straight up and down and right now, but if you look at when he was a child, the upper front teeth were sticking out a little bit, which is okay.
Right. Yeah.
Okay,
Yep. Yeah, I get that too.
okay.
Okay.
So now keep on
Yeah.
going.
I didn't know if you wanted to look at these at all, but
Yeah, maybe upper front looking like they're sticking out. That was only number 9. Okay, and then maybe it just looked more exaggerated because of the exaggerated overjet. Okay, but but so yeah, if you look at the canine relationships, also, it's nicely, it from the look of it, it looks nice, but the way that you could achieve that, I think, is by retroclining the upper teeth a little bit, the canine relationship that they have had, and then to and then to have the lower incisors become, maybe freed up a little bit by lowering them, and then because you know if you think about it, the pre-op, it showed less of the lower front teeth, and your canines starting to have been the gingival line angle, a gingival line starting number 27 seems to be taller than how they are right now in the post-op. So there was tremendous effort by the orthodontist from a typical, you know, onlooking picture to make it look like a nice class 1 relationship. I think the orthodontist did a pretty nice job in terms of that from the look of it. The question is on the functional side. Okay.
right. Okay. I'm gonna
So
go on.
yeah, please go on.
All right, you're gonna love it. Here we go.
Yeah.
So in April, I just had him as you know, I'm making a transition in my practice. So right now I'm taking a pause from clinical practice. I sold my practice and I'm dedicating my time to continuing ed and sanity and plan on, the next steps probably in the fall. But anyway, so I went to our good friend Dr. Fong's office, and Lorenzo had his cleaning and a checkup exam, no decay. And Dr. Fong gave me the privilege of adjusting Lorenzo's current appliance and taking these pictures. So I took these bite marks in just touch. Like I told him, just touch, where
Mm-hmm.
it's just maybe MIP.
Mm-hmm.
And it was early on in the appointment before I adjusted anything.
Mm-hmm.
I took some pictures and then I took these and I said, just touch. And these are the marks.
Mm-hmm.
And I apologize. I didn't get the upper anterior. I'm really like, I'm
That's
going to
okay.
get another picture of
Yeah,
his
that's
upper
okay.
anterior,
Okay.
you know, but I thought was important. Like
Mm-hmm.
his chief complaint is, he always complains about the right side.
Mm-hmm.
He always complained about the right side giving him trouble. I noticed that, like with his bite, the right side is really tight all the time,
Mm-hmm.
and like left side is more open. But I mean, all of this is going to drive me crazy. I mean, I literally don't know what to do with all of that. But I noticed that his number 14 is kicked out. He has lateral excursive interferences. I mean, I am worried about this one. He might get a fracture at some point. His upper anteriors are super erupted. Um, but I'll go on. I'll come back to this picture again, right?
Yeah.
So here it is. I'll show this.
Yes.
Okay. I tried. I'm sorry. I did the best I could. Can I show it again?
I can kind of see, but yeah, let's do one more time.
I should have probably panned out further, like farther away and
Yeah, he doesn't really
stayed
show his
still.
teeth too much, so that's okay.
Yeah,
Maybe
right.
maybe it would have been easier because from at least from the look angle that I'm looking at, if there is an anterior phonetic interference, I think it's to his right side of the anterior. It's not that center anterior. But go ahead. What time?
Yeah, so next time what I'll do is I'll probably try to pan out a little bit further and
And
maybe
then
get
and then and then take the picture, take the video slightly from inferior to his occlusal plane and looking up. Don't take the
yeah,
picture at the same plane as the incisal edge.
okay. Let me try it one more time. I'm gonna see.
Okay. Are you able to increase the volume? Because we don't hear any sound.
So it looks like he's touching there.
That's what I mean. So, but are you able to click on the all the way on the right side of that bar? Is the sound volume? Yeah, all the way there. Oh, that's already up there. So I think it's just
You want me
somehow
to turn
it's
it
not.
up?
Try it, but because we're not hearing anything, we're just looking at the
Oh, okay.
the
Let me
yeah.
try it again.
Yeah, I think when you embedded it, somehow the voice didn't come through. But yeah, so you can see there is slight potential for the front teeth to be touching on the right side, on his right side. Okay.
Yeah.
But in his case, as your markings clearly show, there are other issues.
All right. Hmm.
The question is he touching in the back as well when he is giving the phonetic testing? And my guess is yes. Okay. My guess is yes, but we wouldn't really know that until we frankly do some adjustment and splint therapy on him. But beautiful teeth, just in slightly wrong position.
Um, you couldn't hear it at all?
No, we couldn't hear it all. Now here's
Oh,
another
dang
picture.
it.
So this picture actually tells me something, and that is this. Remember I said if somebody is doing a little pouting of their lips, that means their occlusal plane may be a little too tall, that their video may be a little too much for their musculature. That's why their lip is not naturally closing. So he has a slightly open gate of his upper incisors. Okay, looks cute, looks good, but when he is closing it, you can tell the previous picture. You can tell that yeah, on as I'm looking at it on that one exactly. That is, I don't know if that was maybe while he's speaking, but it
Can
looks
I show
as if.
you this one?
Go ahead.
This is a, I was trying to get him to open and close. I wanted to see his jaw movements.
Yeah,
So,
please. Okay, that's reasonable. So you can see how his occlusal plane is slightly tilted, and his lower incisal plane is slightly tilted. His his right side is a little bit taller, higher than the left side, but no major, deformity or no major, uh, 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 what's the word I'm looking for? No major canting to either to the right or left. Okay, so then this was actually quite helpful. Okay, and so what I'm gonna have to say is that my initial thinking right now is that phonetically he's touching in the molars where you mark the initial contact interferences, and and not only is he phonetically interfering there, but he may be he they are initial contact points where they are violating his video. So he's constantly trying to avoid back teeth touching too much. So he's constantly trying to do this. Okay. And that's obviously very fatiguing. And his joint is constantly being pulled away from stable position. Okay. Now, you didn't tell us if you did any muscle palpations. Did you notice any muscle palpations, soreness?
all right. Well, that's part of the next lecture.
Okay. All right. That's fine.
I can give you my TMJ evaluation. I did like all the TMJ stuff, but I
Yeah.
just wanted to go through this stuff. But
Okay.
yeah,
Okay.
all
Now,
right.
so when I'm looking at that picture, meaningfully, the one on the right side, where you have much more clear contacts that are showing. Okay. Actually, if you want to go back to the other slide, going back a few slides, where you're showing both upper and lower same time, right there. Now, actually, while we're at it, can you do me a favor? Can you show me his post-ops panoramic? I think it was one slide before this. Well, maybe one more. There you go. Is this the post-op slide? I mean, post-op pen?
Yes.
Okay. 2026, by February. Okay. So when you look at that, okay, so he is biting on a bite fork in the front, okay, and his midline is more or less lined up between upper and lower, okay. But take a look at his condylar positions. Okay, so his right side condyle is more retruded and higher up. And when you look at his occlusal plane, that's exactly what's reflected. Okay, now because his midline is not that badly shifted and because he's young, if we can go in and control his occlusion, I think it's not gonna become a like a lifelong characteristic of his jaw. Okay, so what we can say is this: his mandible is definitely trapped in. His mandible needs to be more freed up.
Why is he shifting to the right so much?
Probably because there is some sort of interference. And then
Yeah, I can't figure it out.
maybe his contact between number 2 and number 31 and number 3 and number 30 is so strong he can't really come forward, or he's trying to deviate away from that, okay, by shifting his jaw to the right a little bit subconsciously. But from the look of it, although this marking is nicely marked, but they are probably articulating paper, which means they're a little bit on the thick side, which is fine. It still gives me what I'm looking for here. Okay. I am fairly confident that his initial contact point is indeed number 2 and number 31. Those high marks are not touching at the same time. His true initial contact point is probably only number 2 and 31.
I agree with you. After like analyzing his case so much, just so you know, what you're saying is really consistent with what I saw when I was adjusting his appliance this whole time. So
Yeah,
yeah, 2 and 30. And that's his chief complaint, you know.
right. So now what you need to do is before he goes off to college this fall, we need to do a little bit of occlusal equilibration. So you are
Would
doing
you
a good
adjust
job.
3?
Huh? No,
Would
you
you
need to
adjust 3
you have to
or
touch up
30?
everywhere, but start with 2 and 3. But you have to touch everywhere, you know. It's not just going to be 2 and 3. But so as you are doing your adjustments or calibration on your splint night guard, okay, you're deprogramming him slowly. But there is a limit to how much you can achieve that because achieve with only that because his occlusal contact when he's without the splint is so off. And when he's eating, this is what he has to eat with. And this is a perfect situation where a patient with ortho, post ortho, just little bit of occlusal equilibration. That is, if you know what you're doing, can go a long way in providing occlusal stability that you're looking for, and the whole mascatory system. Okay, so so I
Looking forward.
think, did you say something?
I just want to go forward here with the
Okay,
slides.
okay, yes, yep,
Okay.
okay, go
So
ahead.
here's the situation.
Okay, great.
And again, I just wanted to present the mostly the diagnostic part of the situation rather than I didn't want to go into any sort of diagnosis or
Uh-huh,
treatment. I just wanted to like present his case right now.
uh-huh,
So he had got his braces off and this is his first splint.
mm-hmm,
So basically he tolerated it well, but it fractured on the left side.
mm-hmm,
And the patient consistently complains of familiar muscle discomfort on the right side.
okay,
So I noticed that the cusp on number 14 was really high and it's kind of kicked out.
mm,
And then it fractured right here. And the splint was really thin anyway from the beginning. So I
mm-hmm,
kind of knew it. I knew it wasn't going to last long. But the fracture, I mean, yeah. So this was just like almost like a temporary splint anyway.
mm-hmm,
Because I knew he just had to get used to it, even the fact of putting anything in his mouth. Plus, it was considered to be a retainer. He has a lower retainer on the bottom and then upper hard night guard as a splint and a retainer. So by the time I was trying to balance it, I had to grind down holes, and it was just too thin, and then it broke, but he liked it. Um, but I went on to the next one. So here's this new splint. I delivered it in September.
Okay.
And this is his new splint. It's hard, all hard. And it was really weird. I had to balance it against this. I don't know what's going
Yeah,
on with
that's
these,
okay. Lower Holly. Okay.
but he's tolerating the new splint well.
Mm-hmm.
Um, I don't know. I just thought I would show this to you
Yeah,
again.
yeah. From the look of it, you have not touched his teeth too much.
No, I didn't want to even touch it.
Okay.
Like, I don't want to touch his teeth until I know
Yeah. But
what's
at this
going on.
point, he's not gonna get that much meaningfully better unless we touch his teeth.
Yeah, that's why I wanted to ask you because I don't want to adjust anything until, because I find like if I adjust the tooth, another one comes up. And next thing you know,
Well,
I'm
that's
grinding down.
exactly right. No, you're absolutely right. And that's where many GPs get scared. I understand that. But that's unfortunately the price of the package. And that is you cannot only touch one, or you cannot limit yourself to touch only one or two teeth. Because by the time you get rid of one interference, something else may pop up. And just like when you are doing adjustment, when you are delivering the splint, you initially touch up on the first contact. Well, that doesn't make everything else become even. Something else touches up. You have to keep on calibrating it, and the amount that you grind becomes less and less until you are satisfied with the entirety of the occlusal contact. So same thing occurs with the splint. I mean, I'm sorry, with the dentition. Now, it is also important that we analyze the fact that your paper um, Acufilm. I mean, I'm sorry, the occlusal marking tape is fine, but you know it gives you potentially a lot of false marking. I do believe the context on the number, what we see here, number 30, 30, 31, and number 18 are true context. I do believe that. I'm not convinced if the contact that's showing up on number 26 is truly there. I'm not convinced. I mean, maybe. I'm not convinced. Okay? That could be false marking because of the stiffness of the paper. Okay? So, and certainly, I don't think that's contacting at the same time as number 31 and 30 and 18. So, so you have to sort of like interpret that. You can still use it, but you sort of have to interpret that, and you have to look at things, before you. So, like for example, if you actually go back and show us again upper and lower arch markings at the same time, because I can tell a lot from taking a look at that right there. Okay. Yeah. So you're not really showing us the call it, the incisor. You're right. It would be nice if we can see. However, it tells me a lot. That is, at the very tip of number 7, where there is a little blue mark, that is at the incisal edge. That seems to correspond to number 26 distal incisal edge. Okay? If you look at the picture in the mouth on the frontal picture, okay? Okay, frontal picture. Okay. That's not really how should I put it? It looks like there's a little bit of an overbite. So where they are marking on number 26 distal wouldn't be on the incisal edge of number 7. It should be more lingual if it was true marking. So what that means is that your paper is stiff and it's just giving us a false marking. Okay, that's how I know that was a false mark. Okay, um, and then uh, and then um, when I see the bicuspid markings, the uppers are definitely lighter than the lowers versus the molars. They are consistent, both upper and lower. And that's how I know that the molars are truly touching first. And the bicuspids and the incisors are most likely false marking, or as the mandible sort of rolls. They touch first in the back and then they roll to the front. But yeah, we need to hopefully. I'm fairly confident that after maybe 2 adjustments, he will definitely get better with his pain. In my practice, I would, I would be confident he will notice the pain getting better after the first adjustment, but I don't want to overdo it. So then, second adjustment within about a month or two, that would be pretty good. I don't expect it to be a lot of adjustment, but very strategic. Okay. And then after that, maybe 6 months to a year follow up for a couple of years. And then I think he could be quiet for a very long time.
So, what I'm wondering, should I make sure that his current orthotic is well balanced and get his joints stable
Oh yeah,
and
definitely,
then check
absolutely,
his bite marks?
absolutely against. I mean, the thing is this: if you bite marks onto the splint, yes, so that you can maintain the equal bilateral equal contact, and then the marking of the teeth, yes, so that you can sort of see. But his marking of the teeth may not change much because as soon as you take off the splint and ask him to close down, his bite's getting programmed again. Because
I mean,
you're not truly deprogramming him only with the splint. Because throughout the daytime he's functioning without the splint. He's eating without the splint. He needs to go a little bit on a softer food diet when we're doing some adjustments so that you can decompress the joint pressure, things like that. But this is very typical of certainly post ortho, but a lot of patients we see in our practices.
I can tell you his TMJ issue. So he does not have any popping.
Good.
Um, there are no joint sounds. He has good range of motion and he's not locking closed anywhere.
Hmm.
But you did notice that in his picture, his jaw does kind of deviate.
Hmm. Not too bad
It's
though.
kind of like stuck a little bit. Like, so there is some risk of disc.
In the long run.
Um,
In the long run.
right.
So
So,
before he goes off to college, it will do him a lot of good. But when you start doing that, you may end up touching up in the front. So part of the reason why I think this is happening is, you know, I hate to say this, but this is typical orthodontic result, and that is his front teeth are touching too much. So you have posterior interference, vertical interference, and then anterior horizontal interference in function. And hopefully it won't be too much horizontal interference. Okay, but you won't really know that until you start with controlling the vertical interference in the back.
so
Just
he,
because, mhm,
yeah, so the muscle discomfort you had asked me earlier about the muscle.
mhm,
So I did do a thorough evaluation, but just to let you know that
mhm,
most of the discomfort is going to be like on the very posterior aspect of the border of the masseter.
mhm,
And it's also in that area, like I can't tell, but I think it's like the digastric, posterior digastric, and or the sternocleidomastoid. Like up in this area is
Right,
tender.
right.
And
So,
so
go
he's
ahead.
shifting forward and back.
Right. So actually, I'm gonna blame that more to the lateral pterygoids, both the lateral and medial pterygoids, the pterygoids. Okay. But certainly all those muscles that you mentioned, they're all involved because they're trying to find the best posture there. Let's take a look at page 193, just so that this was going to be our next discussion. So long centric. So your son needs more space for the long centric. He's locked in. Besides posterior unevenness. Take a picture of that drawing in the top portion where Dawson is suggesting that we provide relief for that, okay, so that the lower incisor, okay, okay, can close, as he says, now can close either in CR or from postural position, slightly anterior, without striking the incline of the upper. It looks a lot like what Tom Lee says about make sure your upper front teeth and lower front teeth don't touch too much. And then, if you look at page 195, I know it's not a good picture for what we're talking about, but take a look at figure 19-2. He's talking about how there is a interference in the posterior, okay? That if you do the occlusal adjustment in the back, he's saying, quote unquote, equilibration usually results in an automatic long centric. This results from elimination of the inclines that interfere with closing into centric relation. Okay? So that contact can be made at the most closed vertical either in centric relation or the original maximal intercuspation position. Okay? So it's too bad that we didn't get to talk about long centric. Maybe we do have some time. We can, but this is exactly what these are very common situations with or without ortho. With or without ortho. I'm not trying to blame the orthodontist. Okay? I see this happen a lot. Okay? The key is this. Lorenzo has the benefit of his mom who is able to intervene before this feature becomes a permanent feature as he gets older. He's still young enough, and he's still very pliable and moldable. You know? So that's the key thing, okay? Okay? So key thing that we need to keep in mind here, that this is not unusual. And this is the kind of thing you can imagine, Dr. Mylene, that in most offices, dental offices, and the orthodontic office, this patient's complaint will be completely ignored or not be addressed.
Oh, you want me to tell you something?
Uh-oh.
Okay. So this is funny. So, and again, with respect, and I understand, I mean, I accept and understand the whole situation, but so my friend, Dr. Martin, she's treating all three of my kids, right? So
Okay.
I was at her office with my youngest son who just got his braces on. He's 14. And of course, I was sitting there and I start talking about all she heard is TMJ, blah, 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 blah. I'm like, occlusion, blah, 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 TMJ. And then she's like, I said, what do you think? What do you think? And she said, well, some say, in her study clubs, some of the orthodontists would say that occlusion doesn't exist.
Yeah.
She said it. She said it.
Yeah,
Some might say that occlusion was made up. It
yeah,
doesn't exist.
yeah,
Wouldn't that be convenient? I mean, as a restorative doctor, I would just be like, yeah, that's super convenient. It doesn't matter.
yeah. Exactly, exactly. And 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 you know, these are supposedly the people who claim to be the experts of orthopedic aspect of the occlusion, and yet they completely abandon that, you know. So that's why you know, it's rarity. It's really rare that you're gonna find an orthodontist who will pay attention to this. Really difficult.
Right. So can I ask you real quick before we move on? But
Yeah.
I was just going to ask, what kind of occlusal paper did you want or would you suggest?
So you know, not because it's ideal, but I find it to be the most predictable, is Accufilm 2. Okay? Accufilm
And
2.
do I do occlusal adjustments first? Like, I just don't know how to stage this in relation to the oral splint. Like,
Right, right, right.
if I
So
have him
normally
wearing the oral
normally what
splint,
I will always do is I make sure that the splint is stable and comfortable, and at least about a month in between visits, that the markings on the splint don't change much. At that point, at the beginning of the appointment, I make sure that I just fine tune the night guard adjustment, markings good, and then now I'm ready because that's gonna serve as a baseline, ready for me to do the adjustments on the teeth. Now, when I'm doing the adjustments on the teeth, because it's a upper night guard, upper splint, most likely it's touching. Ideally, it should be touching lower buccal cusps, right?
yes.
So when I'm doing the occlusal adjustment, I try not to touch lower buccal cusp too much. That way, when I'm done with my adjustment of the teeth, I don't have to go back and do too much adjustment on the night guard. If I touch up on my lower buccal cusps while I'm doing the occlusal adjustment, then my night guard occlusion may have to be looked at again and adjust a lot. Okay, so that means, you know, if the lower buccal cusp is hitting the upper, I try to adjust the upper where it's touching, unless it's compromising the dentition too much on the upper. Then I'll go ahead and do some adjustment in the lower. But you know, but like lower lingual cusp, you know, I have no mercy because I don't expect that to touch my splint anyway.
Right. I am concerned about this over here.
Yeah, right.
So,
So and then but that's not just gonna be the lower lingual cusp contact adjustment. I may end up doing upper palatal cusp a little bit. So
yeah,
I'm
like
gonna
here
yeah,
or
exactly,
here.
exactly. So they have
Yeah.
to be touched up there just like that.
Doctor, what do you think about this one on number 3?
Number three, that one may be a false marking.
Okay. All right.
Okay, so
Okay.
you know, yeah, you know, I almost just because this is your son, I almost hesitate to say, but I want to say, if there is any way that I can, when I go up to Northern California next time, if you and I can make a date with your son at a, you know, and we can take a look, I'd be happy to add my 2 cents to,
That would
uh,
be awesome.
you know,
Thank you so much. But I
okay,
wanted to show you the very end here.
uh-huh,
So the follow-up.
yeah,
Um, so right now what's happening is the patient is compliant, which was difficult to get him to actually
initially,
know the reason for the madness. But now he's comfortable with this one. He's actually wearing it.
hmm
His symptoms to be like stable. I mean, he still has some discomfort, but What we're going to do is we're going to follow up and do the splint adjustments and a thorough TMJ evaluation,
Mm-hmm.
probably in a couple months.
Mm-hmm.
And what I realized is his wisdom teeth
Mm-hmm. Yeah.
might be giving us some discomfort. So he's going to have his wisdom teeth out this summer. And then what I can do is I'll follow up with him after he's healed, probably like the winter break. I'm going
Mm-hmm.
to check his appliance again. And then I will take his occlusal marks again with the thinner paper. And I'll present the next time whenever I get that information. I'll present those marks. I'll
Yeah.
get pictures of the upper anterior, a thorough TMJ evaluation, and all of those records. And I'll try to get a better speaking space picture or video, and then bring that to you next time. And
Uh,
hopefully, eventually, I'll be confident enough to do some occlusal adjustments.
yeah. Now, if you show me his panoramic quickly, post-op panoramic.
Sure. Let me see if I can get out of this so I can go
Just
right to it. Hold on.
yeah, if you just reverse it.
I'm going to just go straight to the pano
Okay, there you
here.
go.
Okay.
So this is most recent, right? Panoramic, right?
Yeah.
Yeah, I mean, I guess you can take that out. There, I think most surgeons might say it's
Come on
still a
in.
little bit early, isn't it? Especially the lower.
Well, he went to the oral surgeon for a consult, and Dr. Grombach is scheduling him to take them out.
Okay. Yeah. I mean, yeah, I don't see any major issues, but if because at least according to this X-ray, the number 17 is gonna be a full bony.
Right.
You know, I mean, it's not that the oral surgeon is gonna have a hard time, but what I'm saying is, sometimes they wait. I mean, I know that once you put somebody to sleep, you want to just get done with everything. I definitely can agree that even if they are not erupted yet through the gum tissue, the upper wisdom teeth are definitely problematic. That's gonna be a problem. The lower one, if you ask me, if my patients ask me, I'll say, yeah, if you want, you can wait a little bit for the lower. If you don't mind dealing with the wisdom teeth issue for two separate occasions. Just so that they are a little bit more, shall we say, erupted, so that developed, so that they are not problematic. Now, the oral surgeon may be thinking, before the roots develop on number 17, while there are tooth buds, tooth germs like that, before they develop and they go into the inferior alveolar nerve space, I just want to pop it out so I don't have to worry about it. I could see that logic. So I will defer to the oral surgeon, but if just in case if the oral surgeon says, "Oh, I just thought that we just take them all out at the same time," because while we have them under the sedation, I think if the patient is okay, I would ask the oral surgeon. We don't mind going under twice, but is there a value to waiting for the lowers to be developed a little bit more?
Right. Yeah. And I just thought, as a process of elimination, that, the wisdom teeth, the growth pains of erupting and growing, I wanted to eliminate that as a
Right, right.
contributing
Right. But that
factor
would
to his
be coming
discomfort.
right now mostly from upper, not the lower. That's why. If there was confusion, the referred pain and all that, it would all be primarily from the upper. And the lower teeth are not that close to the second molars. Usually the mandible flares out, So the lower wisdom teeth are actually sitting more buccal than the second molars. So they're not that close to the second molar roots as you may expect. Now, but again, I will defer to the oral surgeon. I just want to let them know that we don't have to take out all four. If there is an argument to be made that we can optimize it by allowing lowers to develop more. But we don't want to wait for the uppers to come down, because if the uppers come down, they're gonna get in the way of mandibular movements.
Okay. I like the idea of the referred pain. I have this chart about all the different referred pain pathways, but I'll look at that later. I might
Okay,
be able to show that to you because the next time I'd like to do like a thorough muscle
sure.
exam. But yeah, he did have some tenderness in his temporalis. Um,
Okay.
the other thing is I just don't understand, like in this picture, the Panorex, why is he shifting to the right? What is it? The chicken before the egg? Like, did it all start from the muscles? Like from his anxiety when he was a kid? Like he's got anxiety. He's nervous. He's a nervous kid. Like he's just really intense, kind of he does everything very
Yeah,
intense.
my guess is actually probably his number 14, number 19 alignment. So he's almost edge to edge there. If you go to occlusal shots, upper and lower, the markings show and the inner digitation. Yeah, you can starting yeah. So if you look at that, you see how number 14 is slightly towards the palatal. I mean, they're both molars, but 14 a little bit more so. Okay. Um, so what that does is if number 19 is to fit within that, the lower entire mandible has to shift a little bit to make that become more normal overjet, rather than just going into where it wants to be. And that probably developed going back to when he was preteen. And if you were to look at his pre-op panel, it doesn't show too much. Okay, yeah. So yeah, exactly. When you look at the 13-year-old picture, you saw number 14 was a little bit more palatal. Okay.
Oh, let me go back. Which one did you want to look at? Oh, this one.
Pre-op. Yeah, right there. So if you look at number 14, that alignment is still there. Number 14. Okay. So so that wasn't necessary. And number 19, you can see it's a little bit more lingually verted. Okay.
Okay.
So at that point, his skeleton didn't really change much yet, because at age 13, his first molars started erupting in when he was what, number age 6 or 7, right? Okay. And his occlusal plane with dentition, permanent dentition, don't really settle until about age 12, when the second molars come in and get established. Okay. So, so since you're asking me why is it shifting, that's to me part of the reason why he was trying to compensate for that. And I see that happen a lot. That's part of my occlusion lecture where I told you that unilateral crossbite tendency is one of the main reasons why the mandibles shift. Now, in his situation, it's very mild. It's only one tooth, right? But so in a way, if if I were to hyper criticize the orthodontist, in a arch development, in a posterior, you know, pushing out a little bit more, right? And then to do and then the mandible as well. Now, at starting at age 13, the orthodontist may say, "Oh, it was already too late." Okay, you know. The suture line in the palate may have already closed up, but that would have been my wish list for that, so to speak.
Right.
Okay.
Okay.
Yeah, but I don't think I think once we occlusally equilibrate him, I think he will be quite stable well into his adult life. I don't think
Yeah.
that's going to be a problem.
Another thing I wanted to mention too is like there's if you notice, I feel like he has very mild symptoms of GERD,
Mm-hmm.
which at this stage nobody's gonna, but the acid erosion,
Mm-hmm.
you know that triad, like
Mm-hmm.
acid erosion, grinding, and then by the time they're like in their 40s, everything's broken down,
Right.
worn down,
Right.
but you
Right.
can see that like there is just like very slight
Yeah.
yellowing. It's like the
Right.
acid erosion, and then he's got geographic tongue.
Right.
And so what I noticed is in part of the TMJ treatment is that the psychological access to part of that diagnosis is that you know from a psychological standpoint, he's clenching. He denies it. I had him write down on his TMJ evaluation intake form history. I had him fill that out and it has a bunch of questions. And he wrote down there that he does clench, but he won't admit it.
Mm-hmm.
He says he doesn't grind at night,
I don't think he's a grinder. He's a clincher, but he's not really a grinder.
right? So he
Right.
he reports that he clenches, but he doesn't grind.
Right. I agree with
And
that.
then but I wouldn't be surprised if some of this is the underlying condition as well as like psychoactive
Well, yeah. I mean,
muscular.
I mean, unfortunately, a lot of young people these days kind of suffer that. But when I look at this post-op picture of ortho, to me, his upper posterior teeth are too straight up and down. They should have been flared out a little bit. His buccal cusps are too tight against the lower, just like the front. They're just too tight. That's very typical orthodontic finish. And it does not give him freedom. So the mandible is locked in.
Right?
Okay. And when I'm looking at that, to be
Yeah.
honest, I'm looking at mandible right now. If I look at that picture, I would say the tongue is probably asking for more space.
Hmm. Yeah.
You know, tongue is somewhat constricted to fit into that space,
Yeah.
you know. So, and I'm not suggesting the orthodontic work is easy, but something is not in balance here, you know.
It was difficult, right? Because
Right,
this is the thing is that he was in orthodontics for a very long time, more than usual.
right, right.
And she had him in rubber bands, like really
Yeah,
aggressive.
yeah, he tried.
And
She tried. Yes, definitely.
but you know what I told him? Because he basically is too smart for his own good. Like he's just, yeah. Like I told him, get off of Google. But he had a lot of criticism about the whole thing.
Hmm.
And he said the being in rubber bands for so long caused TMJ. And, but I told him, and then he was all worried about his skeletal formation. He wanted like his palate to be bigger. There's not enough room for his tongue. His tongue isn't seated in the
Well,
correct
there's some
position,
truth to that. There are some truth
right?
to
So
that.
he's going all about that,
Right.
and so, but it is what it is. I told him it's not a perfect world. And I told her, I said, we need to stop treatment and because it's too aggressive. It's like a bad hair day. Sometimes you just got to let it go and deal with where you're at.
Right.
Um, because, the harmony, it's the harmony. And
Yeah.
the other thing is everybody always asks, like, why? What was it? What was it from the beginning? And I think that it was from the beginning a neuromuscular issue. And basically, because of his psychological profile, and for whatever reason, bruxism exists, whatever reason, like clenching exists, um, I feel like the muscles were fighting the orthodontic treatment the whole time. And that's why it took so long. And that's why she might not have gotten the optimal position of the
Well,
teeth. And then
yes.
also that she wasn't looking at everything. Like this is the thing is that talk about the harmony. The harmony from the treatment from the beginning, like all the different disciplines, they don't coordinate. The orthodontist does what the orthodontist does. And then, we have to look at um his neuromuscular psychologic predisposition, his joint space. I mean, all of these come together
Well,
from the beginning.
unfortunately, you're not going to have any orthodontist. Very few orthodontists will look at all that, unfortunately. Now, since you are up in the Bay Area, in the Northern California, I think I had mentioned to you once before, I'm going to look up this organization about the Nephologic Orthopedic Orthodontic Group while you are in your sabbatical year. Maybe you should consider taking their course. Not that it's going to be a panacea, but that's a quasi-orthodontist group that talks about functional appliances to develop airway, which is in balance with the oropharyngeal muscles and the teeth alignment resulting from that. At least you're looking at your younger son, that's something that might be helpful.
Great. Can you let me
Yeah,
or text
I'll go
or
ahead and find
chat?
it. I don't know exactly
Yeah.
where. It's gonna take a little bit of time. It's been a while. I actually took their entire course series. I think like it was like 8 or 10 lectures. Okay. And they have most of it, about half of it in Walnut Creek. So it's easily driving distance from where you're at. And then I went to Colorado for one session, and then I went to Tacoma, Washington for one session, but that's all part of their series of curriculum. And
Right. And the other thing, I'd love to have that. That would be great. And the other thing I want to mention is that we didn't do a sleep apnea test. We
yeah,
haven't done the oral airway
right.
yet.
It
So
probably has a
for
little
what
bit.
it's worth.
It's certainly,
But thank you
but
for letting me share. I'm going to stop
yeah.
sharing, okay?
Okay. Thank you so much.
Thank you, Dr. Lee. Thank you so much.
Oh, okay. So, Mari, hopefully when I ask for that condylar position pre-op, that answer your question. I just saw your thing. Okay. So, okay. So I think in light of what we just talked about, I think we owe it to ourselves to do a little bit longer and then do a little bit of at least start talking about long centric because it is indeed a very much an important topic, especially as we talk about Lorenzo. Take a look at the picture of on page 189, chapter 19. Okay. And I know that some people had to leave early. That's okay. Okay. But I am gonna put up the recording. Okay. And by the way, I forgot to pause my recording while we were taking the break time. So Moyed and Mari, one of you might have to compress it and then send it to me. Okay? Because I don't want people to be having 20 minutes of just like dark screen. Okay? All right. So that being said, take a look at that picture. What Dawson is saying about long centric is so you have the lower incisor in dotted line. Okay? So what he's saying is in dotted line, centric relation is more retruded. Okay? More retruded. And then in the postural closure, the teeth go forward a little bit more. And yet they are within the same horizontal plane. Okay? Now here is the thing that I probably will spend some time talking about this and then we're going to stop here today. It's page 190. Okay? Upper left, concept of long centric. The centric relation refers to the exact point at which the loaded condyle disc assemblies are braced by bone at the most superior position possible against the eminence. At this loaded position that occurs from firm contraction of the elevator muscles, the disc is compressed and the condylar axis reaches what we refer to as the apex of force position. It is this position that can be located repeatedly and recorded with needlepoint accuracy. Consequently, it is somewhat confusing to think of such precise point as being long, meaning what he's saying is centric relation is such a precise point, it's kind of contradictory to give something long description, right? It has to be a dot, he's saying, okay? This term long centric is misleading because there cannot be such a thing as long precise point. It is even harder to accept the concept of a long centric with the current understanding that the medial pole of the condyle disc assembly is stopped by bone, which is unyielding, at least within the range of normal function. Now, I'm going to stop there. Why do you think Dawson is saying this and there is a contradiction here? You know why? And I said this before in my previous discussion. Because Dawson is thinking of only bone to bone. In a normal Lorenzo's case, the normal patient situation, bone to bone contact does not occur. There is disc. And remember what I say in my occlusion lecture. The CR, and I'm not the one who's saying it, the literature, some of the literature says the CR is a range, is a range. It is not a dot. What they are talking about, the apex and all this and that, they're talking about the retruded or apex location that's most repeatable. Yes, that used to be the definition of CR many years ago. That's for the convenience of the guys who are setting denture teeth. Okay? But when we are looking for a physiological, comfortable position, relationship between upper and lower with the disc in place, depending on your diet, depending on your posture, that condylar position may change a little bit from day to day. We're not locked into one single dot. Okay? Now, he sort of alludes to that because if I keep on reading this, okay, I'm going to keep on reading, okay, the midpoint of the second paragraph. The original concept of long centric probably garners some advocates for the wrong reason because of clearly erroneous belief that condyle either rested in a yielding mass of soft tissue or was simply suspended in space. This is where they make mistakes. Wasn't it Dawson who emphasized to us between upper and lower bone? There is disc. Remember he was talking about how the disc can be displaced? How the disc is compressible? And yet they completely forgot about it. So we cannot forget that. Anyway, moving on, okay? Because both of these beliefs portray the condyles as resting on rather spongy articulations. And I think it's kind of unfair. He is painting the whole scenario as being spongy. Okay. Spongy means like it's kind of unstable. Okay. What if I say that instead of spongy, it's more like how about if we say that the shoes that we walk on, we don't want the shoes to be too soft, like a sponge, but we want the shoe support to just strike the right balance. We don't want it too hard. We want there to be a little bit of a cushion, but that still provides a firm landing support. And that's really the concept of TMJ disc. It's compressible slightly, and yet it's functional in wide range, wide shape, okay? And it provides the stability you're looking for, okay? And this is where the old thinking still comes through and confuses everybody who's reading this book. My guess is this was a lecture that goes back much longer, older. This is an older lecture. While they were still thinking TMJ, they were studying TMJ by looking at dry skulls. Okay? Instead of looking at either dissections or MRI, which make sure that you don't forget there is disc in there. Okay? And then the muscle. After all, after all, um, um, Dawson says nothing will win the muscle. If the muscle wants to have different postures, okay, at rest, well, we need to respect that. As simple as that. Simple as that. Okay. Now, one thing that's very interesting about this is that when they come and talk about all these, okay, they talk about equilibration and all this and that, okay, it purely becomes mechanical. And then they stop talking about phonetics completely. They stop talking about the range of motion. Okay? And that's really the concept of long centric. You could have, even if you believe in pinpoint centric relation, from there, if you allow freedom for the phonetics so that your front teeth don't have fremitus, what ends up happening is you naturally have this long centric. Okay? So I know we spent good amount of time talking about Dr. Mylene's case. I think it's really helpful, Dr. Mylene, for us to see that an actual case. I like when the next time again when we talk about it. So it's typical, okay? In we can say Lorenzo needs long centric. Lorenzo needs wide centric. He's locked in. He's locked in the front and he's locked in the sides. Okay. So I will say this that we're talking about going back to the third molars. If we miss the opportunity and if we wait for the third molars and the lower to continue to erupt, it is possible, theoretically at least, that the entire lower teeth arch segment will go even more forward. And we don't want that. So it's not a bad I don't have any problem if my surgeon has confidence. It's okay to go in and take out the lower teeth. There is very little risk that we're going to take out those lower teeth when we're taking the upper teeth out. I will not oppose their trimming plan. Okay. But if they were thinking like, I want to wait, but it's my colleague's kid, and I'm gonna put the kid to sleep to take out the uppers. I might as well just take the lowers out. It might be a little early, but it's okay. You know what I mean? I mean, if that's their rationale, then I want to just assure them we don't mind waiting for the lowers until later date. Okay, but you need to time it because you don't want the lowers to come up and push against the the second molars, and then that can push the dentition towards the front more because that's one of the things we're fighting.
Dr. Lee.
Yeah.
So, like, I've heard from orthodontists over and over so many times that the wisdom teeth don't push teeth forward. I don't
Well,
know.
they're gonna say that that there is no literature to support that. And my answer to that is I don't have to win this argument in any way, but how do you design a study where that's going to happen? Like, yeah, I mean, yeah, I understand that, but at the same time, we do know we do know that that teeth have mesially drifting tendency. Nobody disputes that, right? So if you have a limited space in the back, and if the dermal is coming forward, coming up, okay, you take a look at those arches before the dermal molars come in. Okay, you have the retromolar pattern ascending ramus going immediately up from the second molar, and you wait until the same patients until the third molars are in. All of a sudden, you have that space there. Now, are you going to tell me that ascending ramus went backwards? You see what I'm saying? No, that didn't go backwards. No. So maybe a little bit, but I'm gonna have to say maybe a little bit. There is a good reason to assume that a little bit went forward too. The problem with orthodontists is that they're incredibly bright people. All right, they usually are the top grade getters in dental school. Them and oral surgeon, right? The only problem is they then rest on their smartness and they don't want to listen to other people. And in my opinion, they're just so tunnel vision. Because when they start talking about occlusion, guess what? They can't make money as much. You know, managing occlusion in an orthodontic case is a headache. And how much extra can they charge? Orthodontic business model is to see as many people as possible within 8 hours a day. I'm sure that orthodontists tried very hard to achieve, what she thought was an ideal thing. The muscle fighting, I'm sure that's true. But as we know by now, it's not the muscle's fault, you know. It's not the muscle's fault. That's how God gave him his muscles, you know. Anyway, okay. So I'd like all of you to kind of go through this section because this is beginning of talking about some occlusal adjustment concepts. Okay, so I don't want to rush through this. Let's read through this one more time. Okay, until next session. Okay, and then we'll continue on. You can see how they kind of overlap into what we talked about before and then introduce a little bit of newer subject and then so forth and so forth. Okay, and so a long centric and the next chapter of occlusal plane of occlusion. Okay, and posterior occlusion, they all go hand in hand, and we're going to be talking about occlusal adjustment, right? How to form the occlusal contour and this and that. I think this will be perfect timing, Dr. Mylene, before you you have your patient in your chair. You know, all of you who are young, you wait until you have your own kid in the chair. You start doubting everything, You don't take anything for granted. You start asking yourself 10,000 questions for something that you've done 10,000 times before. Okay, so I think I'm really excited for this section that's coming up to posterior occlusion. As you know, I consider that a critical part of stability of occlusion. So I'm not gonna give you any new reading assignment until next session. but let's make sure that we read really good. And I don't know about you, but I'm satisfied how we had conducted our discussion today. The so now I am looking. Our next session is June 28th. I'm looking at. Okay. All right. So, oh wow, does that mean by then, Moyat, you're gonna be done with the program? Look at you smiling. I can actually see you are just so much more relaxed today, right? Because you're like saying, whatever happens, I'm done. You have that look of resigning.
I'm done. I'm
I'm
done.
done.
Well done.
Well done. You're well done. Okay. Maybe we should talk before next session. Okay?
Yes, please.
Yeah,
Yes.
yeah. Okay, sounds good, everybody. Okay, thank you so much, everybody. I have somebody coming in to me, see me at my office at noon. I mean, I'm sorry, 1 o'clock. So I would like to be wrapped up before usual, our a little bit early so that I can be prepared for that. Okay? Thank you so
Thanks,
much,
Dr.
everybody.
Lee.
Yes. Have a good day,
Thank
rest of the
you.
day.
Bye.
Enjoy.
Thank you, Doctor.
Thank
Thank
you.
you,
Dr.
Doctor. Bye bye.